Good afternoon, everyone. I'll be presenting a complex endovascular aneurysm repair, which was carried out by Octopus Technique in our institution. We have probably done around 5 cases in the last 1.5 years. This was the most complex of all. So this was a 61-year-old lady who presented with lower limb claudication for the past 2 years. She complained of recent worsening of symptoms. Her claudication distance was 50 meters at presentation. She's a hypertensive for 15 years, and on examination she had absent bilateral femoral pulses. This is the initial CT angiogram, which shows a Crawford extent 5 thoracoabdominal aneurysm arising from the mid-thoracic to the renal level. Other important thing to notice here is a severe wall calcification. And as you can see, the largest dimension is around 8.5 centimeters, which means it could rupture any time. And the other panel here shows bilateral circumferential thick calcium in both iliacs along with stenosis, so which actually bears an important feature in planning the access and therapy. This is the 3D reconstruction image. A subtle point to be noted here are multiple collaterals coming from the SMA to the IMA, from here to here, which sort of suggests there is a chronic tight stenosis in the infrarenal aorta. So this is a cross-sectional image which clearly shows a superimposed thrombotic occlusion on an underlying tight calcific stenosis. This is the superimposed thrombus, which probably is responsible for recent worsening in symptoms. So at this time, what treatment options would you consider? As one would expect, we would always look at the surgeons as an option. We would offer it to the patient, but looking at the iliacs, looking at the extensive calcification, it is going to be a surgeon's nightmare. So there's no way of anastomosing any of the branches to the iliacs here. So that also makes a hybrid repair very less likely. So that leaves us with the only option of an endovascular repair. So of the endovascular repairs, there are many modalities that we could consider. Like custom made or an on-table modified devices like fenestrated or a branch device or a sandwich technique. The problem with all these is we use really large sheath systems, like which are up to 22 to 24 French. Having seen this iliacs, it would be impossible to track any of these devices into the necessary place. And even a surgical iliac conduit for access was not possible because of the extensive deep wall calcium. So that brought us to the 11th amazing fact about the octopus. That's the Octopus Technique. So this is a picture showing various types of endovascular techniques. I would just go to the Octopus Technique. This is the initial image which was described by the group which suggested this technique. As you see, it is a bifurcated device which has a main body, a contra limb, and the main extension limb. So through the contra limb, you could easily access at least 3 of the visceral vessels, and the 4th visceral vessel needs an alternative strategy, like they have used a sandwich technique in this picture. So this comes with a lot of advantages, the most important of which is there is no necessity for individual customization. It is off-the-shelf, ready-to-use device, so which reduces the planning time considerably. Graft limb orientation to visceral vessels is not required, and axillary access provides a simple visceral cannulation from above through the contra limb. This is the contra limb. And the branch graft flexibility is better and tolerates migration without stenosis or occlusion. And also the modular graft configuration provides a good overlap and adequate and durable seal. We are left with a lot of challenges in this patient. The first being infrarenal aortic occlusion, and the second being a severely calcified iliacs, which makes her really a poor candidate for surgery. Not only that, even planning an endovascular repair, tracking an endograft is really challenging. And we also have 4 good visceral branches which need to be preserved. Going on with our first challenge, this is a pigtail angiogram done from the left radial artery, which shows an occlusion at the occlusion just below the left renal artery. You could also appreciate the celiac and SMA arising from the aneurysm, and the right renal artery has significant calcific stenosis here. So on day 1, what we did was we just put a 5F JR from the left radial artery. We stabilized it into the thrombotic portion using the stiff end of a Terumo wire, and we thrombolized her overnight with urokinase for almost 14 hours. And remarkably, the next morning her femoral pulses were present. So if you notice, this angiogram done the subsequent day is actually done from the femoral route. A quick question for any of the residents and junior consultants: what catheter is this? Could you identify? This is not the pigtail angiogram. The clue, I gave you the answer in the question. This is actually the VOTT catheter, VOTT. The two advantages of this is it is over the wire 8F catheter, which enables us to perform angiographies, and presence of the stiff wire while taking the angiogram gives us a working view. So we take an angiogram and immediately on the same wire we go ahead and deploy our endograft. But I have mentioned before the severely diseased iliacs bilaterally. So to take care of the access, we initially started off with stenting bilateral common iliacs. We used a 8 mm balloon expandable stents, and at the time of post dilatation, we used a slightly larger balloon on the right side because that is the side we are taking our main endograft from. So we used a 10 mm balloon and an 8 mm balloon on the left side, and simultaneous high pressure dilatation was done. And this was the deployment of the endurant bifurcated endograft, and the upper margin was in the normal segment marked fluoroscopically, and you could also see the aneurysm calcification here. So we ended well above the aneurysm to ascertain adequate proximal seal. And another important feature in this was we ensured that the short limb of the bifurcated device is facing anteriorly to facilitate the entry into the visceral vessels. The next step, we got access into the visceral arteries and stented them. So in the Octopus technique, the arteries which are above, the superiorly placed arteries are accessed through the contralimb. So from a 14F sheath placed in the left axillary artery, we punctured 3 quadrants of the valve separately, and we got access into the celiac artery, followed by the right renal artery, followed by the superior mesenteric artery sequentially, and we got stiff wires placed inside, and we put multiple self and balloon expandable covered stents respectively. An important parameter is all 3 branch stents are proximally led till the flow divider of the bifurcated device. That is an important thing that one should ensure, that all of them end at the same level in the flow divider of the bifurcated device. So the next part was to secure the left renal artery. So prior to that, we deployed the extension of the endurant main body into the distal terminal aorta, and then we put a periscope strategy stenting into the left renal artery. We used a 5 mm balloon expandable stent. Another important parameter factor that you need to look for is ending the periscope stent below the lower margin of the endurant main body, because that only facilitates the preservation of flow in the left renal. So these are the final angiogram. You could see preservation of flow in all the viscerals and down the aorta, and there's hardly any gradient above and below. There is a small type 4 endoleak, which is because of the graft porosity, which is likely to settle over time. This is a picture of the terminal aorta showing well-flowing iliacs bilaterally. There is a small deep wall dissection in the terminal aorta. However, it is not causing a compromise in the lumen, and the pressures were the same. It was not intervened upon. This is a picture representation, upper panel showing the pre-procedure images. This is with the infrarenal aortic occlusion. This is 14 hours post-thrombolysis, and this is the completion angiogram pictures. This patient had come back for a follow-up 4 months down the line, giving significant improvement in symptoms. The upper panel CT shows aneurysm at various levels. This is the main endurant main body. This is just after the flow divider. It's actually not projected clearly, but you could actually appreciate like a Mercedes-Benz sign. The three grafts entering the visceral arteries have nicely conformed in a triangular shape within the bifurcation limb. And a little lower down, the 3 graft vessels have nicely separated within the aneurysm sac with full thrombosis of the sac. And the lower panel shows 3D reconstruction image of the same with good apposition of the graft to the aortic wall and preservation of flow to all the branches. So coming back to the advantages of Octopus technique, the most important that we need to remember, it's off-label and off-the-shelf device, which has no waiting time and lowest possible profile device, especially in cases where iliacs are severely diseased. It does have some potential complications, like there is a chance for compression or kinking because we're putting large branch grafts, and axillary artery management may pose a trouble. In this patient, we just closed the axillary artery using a fluency self-expanding covered stent. And sometimes in this patient, we had a downward facing branches, so we could easily access from the axillary artery. In some cases, the branches are taking off in an upward direction that can really pose a challenge in getting an entry. So I would like to conclude by saying EVAR for complex aneurysm has significantly lower morbidity compared to surgical repair. Octopus technique using an endurant bifurcated device is an off-label and off-the-shelf strategy that can be rapidly assembled. And 3 branches can be accessed and stented through the contralimb. Optimal sizing of the branches is important to prevent gutter leaks. And the 4th branch needs an alternative strategy, like we use the periscope stenting of the left renal artery. And catheter-guided thrombolysis is useful in recanalizing chronic aortic occlusions. Thank you.
What were the stents used for visceral arteries?
We've used 2 live stream balloon expandable stents, one in the celiac and the right renal artery. And in the SMA, we deployed fluency stents, that is into the artery, but we had to extend it proximally using 3 fluencies, 9, 9 and 8 mm respectively, so that they all end at the flow divider.
So you have to use 2 for each of
because of the length. Because of the length is one.
Fluency, all are fluency.
The one which ends in the main body. So this celiac artery stent was a live stream. This renal artery stent is a live stream. But you see this is not extending till the flow divider of the bifurcated device. So this we proximally extend using fluencies. So it's important. We like fluency because I showed in the follow-up image that they nicely conform to the shape of the bifurcated limb and become triangular. If you use balloon expandable stent, they tend to be more circular and it forms a gutter which will be a cause for endoleak in future.